Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment, Shout, Texas. Echo, please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, click on the speech bubble icon at the bottom of the navigation bar at the bottom of your window. To all the BWell Texas providers, please make sure that you identify yourselves during this session. Or if you're joining via phone, please email your phone number and name to bwelltx@unisca.edu. Some housekeeping, please stay muted unless you're speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you joined by phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow others to speak up. Please note that no protected health information is allowed in either the chat or the discussions, and this includes names, emails, addresses, or any information that can easily identify an individual. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Shout Texas Echo team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on managing OUD in patients with perioperative pain and will be presented by Dr. Blair Walker. Following that, we will discuss a case presented by Dr. Daniel Levin. We will start with some introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach and all learn, we encourage you all to share your questions, experiences, and insights in today's conversation. And with that, we will move on to some introductions. Dr. Walker.
Hi, everybody. I'm Blair Walker. I am a psychiatrist here in Austin, Texas with the University of Texas Dell Medical School and working for Ascension Hospitals. Thanks for having me and part of the hub team.
Thank you so much for joining us. Dr. Lindsay.
Hi, everyone. Adrienne Lindsay, Director for the Center for Substance Use Training and Telementoring here at UT Health at BWell, Texas. Thanks for being here.
Thank you so much for joining us today. Dr. Lavin.
Hello, I am Dan Lavin. I'm an addiction psychiatrist at Baylor Scott & White Temple. I'm the division leader of the addiction division here, the addiction themed programs, and I'll be giving the case presentation as well.
Thank you so much for joining us today. Alana.
Hi, good afternoon, everyone. My name is Alana Bolton. I am the director of Shout Texas, which is a program at Dell Medical School at the University of Texas at Austin. Thanks so much for being here today.
Thank you so much. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm a CSTAT program coordinator. Thank you for joining us today.
Thank you. And with that, we will move on to our didactics. Dr. Walker, you can take it away whenever you're ready.
Sure, if you guys could screen share. Perfect. So thank you for having me. We're going to talk about the reverse of what was discussed, which is just acute pain management for patients with opioid use disorder. And like I said, I'm an assistant professor of psychiatry with the medical school here in Austin, Texas. You can go to the next slide. Just basic disclosures. Neither I nor any of the members of the planning committee have any financial relationships that are relevant to disclose. And these are just our opinions. So next slide. Bit of a double of it, but I did want to thank John Weems. We gave a talk very similar to this in the last couple of years, and it's been updated a little bit. You can go to the next slide. And just go ahead and slide through. So learning objectives, we'll talk about kind of myths associated with the treating acute pain, principles about treating pain for patients with opioid use disorder, and just some management strategies for patients on methadone, buprenorphine, and naltrexone. You go slide forward. So myths about pain and opioid use disorder, and they're still ongoing. There's still a lot of stigma about treating patients with opioid use disorder and just tension in the treatment. One big myth is that opioids are ineffective for pain in patients with opioid use disorder. Another big one is that buprenorphine and methadone for treatment of opioid use disorder will treat pain. They can treat pain, but sometimes need more doses and not always, and we'll talk about that. And then a myth that buprenorphine and methadone both block all opioids. Go to the next slide. There's another myth that it's illegal to prescribe opioids for pain to patients with opioid use disorder. It's a little bit complicated and we'll talk about it. But prescribing opioids for opioid withdrawal is not sanctioned. Pain is okay, but risky without someone being on opioid use disorder treatment. And another myth is just the idea that opioid exposure always means relapse risk. And, you know, the opposite is sometimes true. Pain is very undertreated and a huge trigger potentially to return to use of opioids. So not treating pain is a risk. You can go to the next slide. So basic principles. And I think the most important thing when you're taking care of all patients, all people, is being very patient-centered, really talking about the risks and benefits, laying out a platter of options, letting patients choose what works with them, and being very transparent. Really just trying to be, you know, treating patients and giving them autonomy and really kind of upholding their dignity with every interaction. There's really no wrong door for treatment. And again, sort of like laying out these different options so that someone can choose what works for them best. And so that sort of aligns with the last kind of idea, is sort of being flexible. You know, I have think like doctors is a little bit of an old slide, maybe think like scientists, be curious is sort of the idea. Don't just sort of kind of write things off. Instead, develop really a differential for any challenging behavior you're coming up with. You know, what is really going on? Is this a substance use disorder? Is this withdrawal? Is this pain? You know, lack of sleep? Is this something psychiatric? Is there something else going on? And instead of just assuming and kind of anchoring in the wrong thing. And most importantly, just being flexible within reason. Go to the next slide. This is a nice slide from a few years ago. Really just the idea, it applies to all patients with opioid use disorder, not just on buprenorphine, but the idea that each individual's situation is different and you can tailor their care and their options depending on the different kind of attributes of what's going on. And so the idea is, you know, each person's environment or situation is different. What are their social supports? What are their risks? You know, what's going on in their life and where they're going to be when they're dealing with this acute pain. What is the nature of the actual acute pain? Is this something where they're going to be in the hospital for a while? Are they going straight to outpatient? You know, how many opioids are really going to be, you know, how severe is the pain expected to be? Or is this a really minor procedure? You know, are you able to do things like anesthetic blocks, regional anesthetics? And then, you know, being, you know, including the patient, obviously, and, you know, what their preferences are, what their prior experiences are, you know, what they're on now, those sorts of things. I just liked this idea of sort of a framework of looking at the different angles of what helps you decide on what you're willing to offer and kind of work with the patient on. So you can go to the next slide. So again, sort of basic principles of treating acute pain, always addressing withdrawal as quickly as possible. Can't really help someone with their acute pain if they've left against medical advice. To give you my background, like I'm working in medical hospitals, a lot of times patients don't have the luxury of planning for the acute pain episode. So I'm working in the trauma hospitals. People have had terrible car wrecks or a burn or something. And so they sort of land unexpectedly into the hospital. So always treating withdrawal quickly and knowing, you know, asking them if they're already on medications for opioid use disorder, knowing the details, knowing that buprenorphine and methadone can be good options for pain control, but they may also need short-acting opioids in addition. And remembering, like we talked about, giving opioids does not necessarily worsen a patient's substance use disorder. but also anticipating tolerance and the need for higher opioid dosing. And I think that's an area where seems to always be a tension in, I'm a consultant in the treating teams and the surgery teams or whoever is managing the acute pain. I think there's a natural tension of having a reticence to use opioids in someone who's struggled with an addiction to opioids. And it's natural, but I think you also can't torture people and undertreat their pain as well. It's a big trigger for return to use. So go to the next slide. So, approaches, we talked about addressing withdrawal rapidly. Are they already on these? What do they prefer? What are their prior experiences? And kind of exploring what they prefer. Always using multimodal adjuncts, so meaning like non-narcotic options, NSAIDs like ibuprofen, Toradol, Tylenol, gabapentin, things like that. And then not forgetting opioid adjuncts, anticipating higher dosing needs potentially. You can go to the next slide. So 3 FDA-approved medications for opioid use disorder: methadone, buprenorphine, and naltrexone. We've talked a lot about these. I'm not going to go into detail. We've talked about them in other shout sessions. But those are kind of the 3 options. I think you can go to the next slide. I think just kind of scroll through. So, I think keeping in mind that methadone and buprenorphine are opioids, naltrexone is an opioid blocker. When you're dealing with methadone and buprenorphine, typically going to be continuing home dose, checking kind of PMP for buprenorphine prescriptions, but realize that methadone, if they're getting it in a narcotics treatment program, which they should if they have opioid use disorder, it's not reportable to the pharmacy board. So you have to call to confirm the methadone dose. Typically, narcotic treatment programs are closed on Sundays, but otherwise open for at least the mornings. And, I think remembering, and if you're guiding from afar, that the prescribers are experts at the OTP. So they can also guide on what to do. Always consider split dosing. Both methadone and buprenorphine do better for pain control when they're split. But realize that it can sometimes contribute with methadone to being a little bit more complicated in discharge. What we found in Austin, and it may be different in other areas of Texas, is because the methadone clinics can't split dosing for pain control typically. If you're trying to discharge to a nursing facility and they're going to take over the prescription, you need to have transition the patient back to single, like once a day dosing before they go, so that they can continue on, and you can ensure that their pain is controlled on that with whatever else they need. And then the third, just considering additional full agonist opioids, and that because of tolerance, and because of the way buprenorphine can compete with other opioids, they may require higher doses than normal. So go to the next slide. So thinking about methadone specifically, we talked about the split dosing. Remember that it always has a risk of QT prolongation. There are fair few drug-drug interactions, and it's a very potent opioid. It builds up slowly over time. And so you can see on the left side, how long it takes to sort of reach steady state. You have to be cautious as you're raising the dose to not go too fast so that you don't accidentally overdose them, because it kind of builds up and it takes 4 or 5 days to really hit steady state for that dose. That doesn't mean that you have to go that slow in medical hospitals though, and we routinely go faster than that. But once we get to doses past 60 and certainly doses up to 90, we're definitely slowing down and waiting several days before we increase. And we're only going up usually by about 10 milligrams every few days once we get past 60, because the risk for overdose is higher when you get to doses past 60 milligrams a day. So it's just something to kind of bear in mind. It is still, you can get people out of withdrawal very quickly within a day or so, sometimes even faster than that. The other big thing about methadone is that when patients have opioid use disorder, we cannot prescribe them the methadone when they leave. And this is still continues to be a little bit of a like a confusion point. Like I even got a phone call just last week when someone was asking me, can't we give 3 days out of the ER of methadone, not for opioid use disorder? You can for pain, but not for opioid use disorder. So that can be a barrier depending on your area and how easy, if someone is not already established with a methadone clinic, how easy it is to get them into a methadone clinic in your area. And usually it's not that easy. And so that can play into when you're discussing with a patient if they want to use methadone for both opioid use disorder and pain when they come to you. Do they have it readily available because you can't prescribe it when they leave? So you can go to the next slide. Thank you. So this, I don't think I need to go through this. I sort of mentioned it a little bit, but I wanted it to be in the slide set so you had it. This is sort of a fairly stereotypical kind of methadone start for somebody who's not already on methadone, but who is tolerant to opioids. And so, you know, I will say if I have a patient who is in active opioid withdrawal and we have very clear suspicion, especially in the days of fentanyl use with much higher tolerance, that they're very tolerant, that at least 10 to 20 milligrams of methadone as a first dose. Often the first day we'll give 30 and then a 10 later, or 20 twice a day. But we don't go past 40 in the first 24 hours. And if we need to be more generous with short acting opioids, if we need to be. So it's just a nice kind of brief kind of dosing guideline that you can refer back to later if you need to. We go to the next slide. So switching to buprenorphine, as I mentioned before, it is also an opioid, but it's a high affinity, low potency, slow dissociating opioid. So it's a lower potency than methadone, and we think it has somewhat of a ceiling effect as far as how much potency you can get to. It binds tightly and it dissociates slowly, and so it competes aggressively with other opioids. And that's where that precipitated withdrawal risk that, you know, everyone is always very worried about, and understandably so, is present. If you give it, if someone's not taking it already and they're tolerant to other opioids and you give it too soon and not in withdrawal yet, you can precipitate withdrawal. Buprenorphine, though it's not a full agonist opioid, I have had much success in treating very severe acute pain. And I think the most important thing is to remember that every patient is different. Every patient's mu receptor polymorphisms are different. Every patient's pain tolerance is different. And so you can have the exact same injury, and one patient really cannot tolerate buprenorphine as their primary pain control, and someone else does beautifully on it. And so, you know, I think just having open discussions with your patients about it and trying and then being flexible if it's not working. So for pain control specifically, we're always splitting dosing. The typical kind of max daily dose these days, especially with fentanyl tolerance, is between 24 and 32 milligrams for many people. That often can reduce later if they're stable and outpatient, but for kind of acute pain, it's reasonable and usually well tolerated. Just a reminder that there's no more training required. Anyone who could prescribe DEA Schedule 3, so that's the same as benzodiazepines, can prescribe buprenorphine on discharge, which is still something that, even though it's been more than a year now, a lot of providers out there, that stigma is still hanging around and they have questions and they're wondering, are they allowed pain? And then, you know, looking to the right, this last section is sort of related to this right graph. We think that there's sort of a change in the percent receptor availability and sort of an analgesic sweet spot, and that if you get doses too high, it competes too strongly with other on to be, and pain is just not managed on what the patient's on, say they're on 8 milligrams of buprenorphine 3 times a day, for instance, then you could think about dropping the doses to sort of free up some of those receptors so that the full agonist opioids can work a little bit better. But generally, the recommendation is to always keep at least a little bit of buprenorphine around. I have had patients who've preferred to drop their buprenorphine dose down to like 2 milligrams a day. And in the days just prior to discharging out, we sort of flip-flopped and increased their buprenorphine, and they did really well that way. And again, being sort of patient-centered and mentioned on this slide, but is something good to know when you have patients who aren't on buprenorphine yet. They're highly tolerant to opioids. They're coming in with acute pain. The other thing that we commonly do that I'm not sure I mentioned in the next slides is opioid bridging. So using full agonist opioids to let the fentanyl that we think is in their system leach out of their system over several days, 2 or 3 days, if you have the ability to do that, if you're in the hospital. And then once the fentanyl's out of their system, it is much easier to switch people over to buprenorphine or to start a very low dose and sort of microdose over time. So you can go to the next slide. So naltrexone and clinical considerations. Naltrexone makes things very complicated. If someone's taking, and if they've taken it that day and they've had a car wreck or something, you can give enough opioid to overcome the opioid blocking effects of pretty complicated. As you can see, they have a pretty near complete mu receptor blockade. And so being generous with dosing, apologetic that it's going to be erratic and difficult to manage pain if they have really severe pain. Coming out of the hospital, being on naltrexone, if it's leaching out of their system by the time they're there, they'll be not tolerant to opioids because it's not an opioid and they are high risk for overdose. You can go to the next slide. And then just a brief mention of non-opioid strategies, multimodal pain control. So we talked about some of these already, but don't forget kind of nerve-related pain, gabapentin, Lyrica, pregabalin, although there is emerging literature around misuse and overdose risk with kind of the synergy of using those in addition to opioids. Always, if you have it available, local and regional anesthesia. So working with your anesthesia teams to do blocks and things should give some temporary pain relief, especially in the few days after like a certain procedure that's in an area where you could potentially block, can make a really big difference in sparing the use of opioids and just giving patients like much more relief. And then anticipating as the block is coming off that they may have kind of some rebound pain and it's going to be a little bit more difficult for usually that first day and sort of helping them cope ahead with that. Think about ketamine. There's emerging literature about it. I'm not going to go into detail about it. That might actually be an interesting lecture to be doing in the future. But we use ketamine drips in low doses routinely on the burn unit when it's indicated and needed. It can work very well. And just something to think about and potentially kind of explore and add into your tool belt if you've never used it before. And then thinking about anxiety control. I think within reason, especially when you're in the medical hospital, offering benzodiazepines, some of which have pretty potent muscle relaxation effects, is not inappropriate, but it's always eyes wide open discussions with your patients and being really clear about where your comfort level is about even considering prescriptions on discharge, which because anxiety and pain really do feed off of each other and one worsens the other. So, you know, I think attending to that is important. You can go to the next slide. So this is just another nice slide about various perioperative pain management options, sort of from the anesthesia side. This is from the British Journal of Anesthesia, thinking about various options. We've mostly talked about them. You can go to the next slide. Just to recap, and again, I think the most important thing is being patient-centered, communicative, and flexible within reason will serve you. Realizing that buprenorphine and methadone can treat pain, but you have to be, you may have to increase dosing, and you may need to be quite aggressive with adjunctive full agonist opioids as well. Always call the outpatient prescribers to let them help you as well. And don't forget to address withdrawal. Using lots of multimodal non-narcotic agents as well can usually give some relief. And don't forget the Narcan prescriptions on DC for all of these patients, please, to avoid accidental death or death and accidental overdose. I think that's it. Go to the next slide. Yeah.
Wonderful presentation. I am going to open up the floor for any questions or comments. Lindsay.
Yeah, I was wondering, so what I see more often than not is prescribers giving everybody tramadol now. That seems to be the popular thing, is tramadol, right? How does that play into all of this? I know from the flip side of it, it doesn't work for me. I don't know anybody that does work for, but it still seems to be the most commonly used opioid.
Welcome anybody else hopping in to give their opinion as well, because this is, shout out go now, like, open to the group. But from my standpoint, it was made Schedule 3. So that's sort of the history of it. Several years ago, it turned into DEA Schedule 3. And so because it wasn't as controlled Schedule 2, and back in the day when we had paper triplicate prescriptions and only the, attendings and not the residents could prescribe it, it started to become a more commonly prescribed opioid. In my experience, it's not as potent. It also has a lot of drug interactions. In fact, fairly recently, my palliative care colleagues taught me it also is highly serotonergic. So I as a consulting psychiatrist in the hospitals, and I get called for kind of wacky confusion states. I've had countless tramadol induced when someone's on other serotonergic agents like antidepressants and things like that, that it has tipped the balance. So for that reason, it's another reason to be a little bit cautious, especially with buprenorphine, which is also one that can be serotonergic, and that since we're using higher doses these days of buprenorphine for a lot of people due to their tolerance, I've had several cases of serotonin syndrome, even on buprenorphine monotherapy. So it's messy, but I think it's because there's this perception that it's safer or, easier to use or something. And I think it's coming from that DEA schedule change that was several years ago, but I don't know that that bears out in the evidence. That's kind of the best I know. I don't know if anyone else has any other thought about it.
Thank you.
Kristen, you had a question?
Yes, thank you for your presentation. I love attending your lectures and the personality that you inject in everything. I'm in long-term recovery from opioid use disorder, and I had surgery a year ago, and I intentionally did not disclose to my surgeon that I was in recovery, specifically because I was afraid of what would happen. Like, I would have a 5-hour procedure and then get on tramadol, right? And you're absolutely right. My trigger is not medication, it's pain. It has always been pain. When you encounter physicians or other practitioners that do not know anything about recovery, or the 12 steps, or the risks long term of relapse with, they just don't understand. They have the evidence, but they don't have a peer lens, right? Or maybe there's some stigma there. What do you say to them to bring them over to the side of science and compassion and empathy altogether?
That's a hard one.
Yeah.
And I appreciate you sharing that personal information. I think sort of speaking in generalities, we're talking about a lack of understanding and a lot of stigma. And it's still very present. And I think it's kind of a work in progress, just like to speak in general. If you're asking how I do that as a provider, oh, sorry, my office does this. If you're asking about how that happens as a provider, I'm just always advocating and educating. I think it's really hard when you're the patient. And so, I don't blame you, and I would expect that a lot of people are in that same situation and feel like it's not safe kind of to talk about it, and then they're going to be treated in a way and treated in, with not given appropriate prescriptions and things like that. I think it's this really hard tension of trying to have, honesty and an open, trusting relationship with your providers, but knowing that there's this risk. And I don't have a good answer for it. I don't know if anyone else does. But I think as a colleague, with other doctors and providers, really, I'm working all the time on empowering them to feel comfortable and educating them with what is okay. And what is ideal, what is okay, to be flexible, the things that we've talked about already. So this is actually a lecture that's been given to physicians, including like our whole county. So
Thank you for that. And I would love to watch a recording of that lecture too. But I also wanted to mention, like, I put off having this surgery for 5 years because of the fear of what I was going to go through if I was found out, or if the surgeon knew about my history, right? And I know that is the risk in general of stigma. People avoid healthcare workers because they're afraid of how they're going to be treated, right? And I just want to impress upon everybody, even with almost 10 years in recovery and a bunch of initials after my name, like, it was still a very difficult situation, and I still didn't, disclose, which is also a risk factor. So thanks.
thank you.
Thank you. I see a question here in the chat. For patients chronically on buprenorphine and going for surgery, how low would you lower the buprenorphine in the pre-op setting?
That's a good question. I think I would generally not do it for very long. And again, when you have and I don't know what the evidence actually says out there, to be honest, because my patient population is very much like I said, like acute traumas just sort of get stuck. What I can tell you is that people who come in on high dose buprenorphine, you can overcome the buprenorphine and compete with a strong enough opioid dose. So it's not like, we have plenty of patients who come in on buprenorphine 3 times a day or 24 in a day, and then they have surgery with fentanyl and they don't have any problem getting an effective dose in. And a lot of times it's not even necessarily that much bigger of a dose. So, I think it's not for me necessarily an automatic, as part of the plan, you've got to reduce your dose. It's just sort of a discussion about what do they prefer, how have their prior experiences been, sort of what we talked about, like how bad the pain is expected to be, how afraid are they of the pain. But I think you can get away with it, maybe sort of like half-life time, like 3-4 days. I'd be worried about, going too long ahead of time, and then they're at risk for having trouble, like returning to use, like before their surgery even happens. And again, that's also a very patient-centered discussion about their prior experiences on lower doses and things like that. I don't know if anyone else has any other thoughts about that.
This is Dr. Lava. Do you mind if I add just a couple of
Please do.
comments? Yeah, and I think, again, thank you for all the information you brought in that wonderful presentation. I'll precede this by saying I think a lot of this is just provider preference. And so this is going to depend on a whole lot of stuff that is different each time. But what I've done as far as preoperative management is usually, assuming it's a planned surgery, make the changes the day of. Sometimes the day before, but usually the day of. And the things that I'm thinking about are how much pain do we expect the patient to experience during the surgery? Like, what is the, what's the anticipated pain from that? The limited literature that I've seen has suggested that at 12 to 16 milligrams a day, you still have about 10 to 15% of the receptors open to allow for additional opioid treatments to take effect. Of course, there's lots of non-opioid treatments as well, as Dr. Walker was mentioning earlier. And then the biggest thing, honestly, I think it's probably just more of an art unless you have to do it this way. But the one area that I sort of get really concerned about usually has to do with the lack of familiarity with buprenorphine in the hospital. And what oftentimes can happen is, unless you counsel the patient, the buprenorphine is usually stopped and either held at the time of discharge, or it's resumed at some point when they have other opioids in their system, they experience a withdrawal. So usually I counsel the patient quite a bit. Hey, you need to be vocal. You need to tell your provider XYZ. If it's at our hospital, please ask them to involve me and that sort of thing. So I think just sort of arming the patient with the knowledge is probably, possibly the most helpful thing, in my opinion.
Thank you, Dr. Lavin, and thank you, Dr. Walker, again for this wonderful presentation. I will please keep the question coming in the chat, but we will now move on to the next part of our session. Karen, if you could please share the announcements. To claim your CME credits, you must text by midnight tonight. Please text the 100-95644 to 844-502-1338. Next slide. Do you have a difficult case that you or your team have encountered? CSTEL gives you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and the broader learning community. There is no need to prepare a formal presentation. We will provide you a case form to fill out to assist with the presentation. Please email us at shouttx@austin.utexas.edu, and we'll drop this email in the chat. Next slide. Join CSTAT for our session titled Implications of Long COVID in People with Substance Use Disorder on Tuesday, March 26th. You can register for this session using the link in the chat. Next slide. It's time of the year to renew our series. You will be receiving a separate notification email today from Zoom that will provide you all the information. So please add the series to your calendar. Next slide. And join us for our next Shout Echo session on Thursday, April 18th for a session with Dr. Christian. And with that, we will move on to our case. Karen, if you could please bring up the case form, and Dr. Lavin, you can take it away whenever you're ready.
Sure. Thank you so much. Again, thank you, Dr. Walker. So I think, full disclosure, this is not necessarily a case about perioperative management, but I think it does hit on some of the themes that Dr. Walker and Ms. Clancy discussed, specifically with, basically how do you treat pain in somebody who has a history of substance use, whether that's opioids or other things. So I am not going to read this out loud. So I'm going to give folks just a minute here to read, and yeah, thank you so much.
If you could just summarize some of the key points from the case, that would be helpful.
Okay, well, I can do that too. Okay, so this is a patient I saw in the outpatient setting, right? And basically the back story is that the patient came to me not for a substance-related problem on the face of it, but for a problem with psychosis. And the patient had been hospitalized, had received some treatment in an inpatient psychiatric hospital, mostly antipsychotic medications. They did have some improvement in their symptoms, which was primarily delusional thoughts, not hallucinations, but delusional thoughts. And really, that's why they were coming to see me. So I do kind of both in the outpatient setting. In talking with them, just the history really did not support things that you think might be present, like schizophrenia or things like that. there was some substance use history, but for a lot of different reasons that really wasn't something that we could delve into the first visit. If you could just pause it there for a second, please. So that's something we could not delve into very much in the first visit. And I think the biggest thing was this patient, despite being in the hospital for X amount of time and on these medicines, was so uncomfortable, so anxious and paranoid about the delusions that getting them actually into my office was a big step for folks. And then even while they were there, we did things like keep the door open, keep the exit clear, all that kind of stuff, because there was a lot of discomfort on behalf of the patient. So at any rate, so we started with some of the basics, and the first visit was really all about, hey, what can we use at our disposal to help the patient feel better, to work on the delusions and work on the anxiety and that sort of thing. This patient did not have insurance, no medication coverage. So what we did is actually just increase the antipsychotic a little bit, both at night and then smaller doses during the day, which oftentimes can help out, give kind of an anxiolytic sedation, if you will. And then we had the patient come back in about, I want to say it was 2 weeks or so. And that's really where I think the bulk of the history came out. So this is a patient that has, could you scroll down, please? Okay. I don't necessarily think the psychiatric history is super interesting here, other than the hospitalizations, the psychiatric hospitalizations had been distant and primarily from complications of stimulant use, but those were all 10 years prior. So anyway, so they come back and I talk with them a little bit more, and the history comes out a little bit more. And basically, this is a patient that has had chronic pain, has had some hip dysplasia and just lots of pain with basic ADL completion, walking, and that sort of thing. And because of a lack of insurance, and I think more so because of a concern about potential bias from healthcare providers when discussing their substance use history, which did involve some opioids as well as other things in the past, they really did not feel like, one, they could share that history with people openly, and two, that they would get appropriate treatment for their pain. And so they did, I think, what a lot of our patients do is try to manage what they have. And this particular patient started to use marijuana again, and lots of different types of marijuana. But for the sake of discussion, a lot of what's available now, as far as the Delta 8 and Delta 10, it may have other chemicals in it, basically other cannabinoid chemicals that sometimes are stronger or last longer, and in some cases can predispose somebody to psychosis a little bit sort of with more frequency than what you'd expect. Certainly if they have a history of becoming psychotic with substance use in the past. So that essentially is what was going on. Digging a little bit further, there was a distant history of basically illicit opioid use. And this started as iatrogenic use, like most folks, just overusing what was prescribed. Eventually, that led to termination of care. The person was obtaining opioids from non-prescribed sources. But that was all more or less in remission. So let me pause here for a second. One of the things I would encourage everybody to think about is, does your threshold for diagnosing opioid use disorder and therefore offering treatment, does that change depending on what the history is? And sometimes I will find myself with cases of opioid use disorder that is essentially in remission and stable, but there's still, in my opinion, a really profound role for something like buprenorphine to provide. And so that's what I did here. I started buprenorphine at a lower dose, basically targeting the chronic pain. This allowed them to stop using marijuana, really get back to a more functional lifestyle. They're able to walk around, help their spouse out with work, that sort of thing. But because they no longer were turning to the marijuana for pain control, the psychosis really went away very, very quickly. And so it turned out well. And then it also did qualify them for basically some community treatment programs that could continue the Suboxone. There's something I was going to point to me one second here. So in this particular case, I think, again, it's not necessarily perioperative management, but it is a good example of basically what our patients sometimes will put themselves through because they're worried about not getting effective treatments. And a lot of times, I think opioid use disorder can present like anything but. So if you can dig out that history, sometimes you can start things that may not seem appropriate at the moment, but can be really helpful. I think that's really about it. Are there any questions on that? Comments, concerns?
Thank you so much, Dr. Lavin, for this great case. And I will open up the floor for any questions, or if anybody would like to share a similar experience.
It's a great case. I wanted to also address your questions in the case, Dr. Lavin, and you sort of touched on them already a little bit, but like, what are people seeing? I think the first one was sort of like the percentage of opioid use disorder from iatrogenic use in your personal practice. I don't have a great data set in what I do in the medical hospitals, but I can tell you anecdotally, it's common to hear people say that that's where it started, with a prescription of an opioid. And I mean, it makes sense if that's where you get exposed to it, and then that, that's the first time that your brain goes, ooh, opioids. I looked it up online in anticipation of this because I was like, I don't know, what is the percentage out there? And it's like widely varied, and it feels, what I could find felt underappreciated. For instance, like the American Medical Association lists somewhere between 3 and 19% of people who are prescribed opioids develop addiction. But there was an article I found in 2015 by Boscarini in a group, and they basically did, from 2018 on, they looked back in a big healthcare system of everyone with opioid prescriptions, and then they were able to do telephone interviews with 705 people. And they came up with, since there's a wide spectrum of mild, moderate to severe opioid use disorder, they had on average about 40% of people met criteria at some point in their life for having at least a mild, and some had moderate to severe opioid use disorders. I don't know if we know. It sounds like you see it very commonly too, Dr. Lavin. I'm curious if anybody else has any other thoughts about that particular question from the case. Yeah, Melissa says 40% sounds more realistic. I think it's common. I think it's also something that when we're prescribing opioids to people, to really educate them about it and what to look out for. To talk more about the sort of second idea, and the idea of like this idea of someone who has had a history of opioid use disorder. It doesn't seem like it's the main active issue, but when do you diagnose it to try to be able to get people buprenorphine? It sounds like you were kind of criteria. But if I feel like I've seen patients that are using things like cannabis, but also a lot of alcohol. So they have like comorbid chronic pain, at some point a history of misuse of opioids, and they're sort of drinking their life away to manage the pain. And, I look at buprenorphine as, the lower risk, most appropriate treatment. We have the luxury in Austin, we have sort of addiction medicine clinic now for patients who don't have funding. So they can be seen not just for opioid use disorder, but also alcohol use disorder and other use disorders. But I tend to be, maybe it's a mild opioid use disorder, maybe it's in remission now, but they're high risk for it returning with chronic pain. And we're expecting the buprenorphine will help them drink less or not at all. So let's try, since they're using alcohol to try pain. So, if I don't feel comfortable ever like fudging a diagnosis, but I feel like if someone has a history of misuse of opioids, it's there, it's a risk, it's something. And I don't know if other people have that experience or not.
So let me just speak for a minute or two, and thank you for sharing that while other folks are maybe gathering their thoughts. So I think I agree with you. Like I have not found any straightforward source on how many people exposed or what percentage of people exposed to opioids develop a problem with it. But the SAMHSA folks, their national survey on drug use, basically the annual survey shows that of folks who meet criteria, consistently 90% are iatrogenic development, right? And that's something I try to hammer home with the residents that are rotating with me, and only because I think, you know, I practice in a smaller town, and I think sometimes the obvious markers of opioid use disorder, we don't have those as much. And I think sometimes that really leads us to missing the diagnosis, underdiagnosing, that sort of thing. And so there are lots of cases where it's the opioid use disorders, the chronic pain is the problem, but it doesn't look like that. It may look like rampant alcohol use, like you're saying. And I think sometimes, you know, I can see teams that consult us say, hey, I called you for alcohol withdrawal. Why are you putting them on Suboxone? That sort of thing. And so just sort of highlighting that, hey, that's, you know, sometimes there's a role, even if it's in remission. I agree with you. You can't make stuff up. But I mean, if there's a history there and they can improve with initiation of Suboxone, even if it's to help them not drink or something like that, that's great. So it's good to hear other folks doing that as well too. I feel like we hear about heroin, we hear about fentanyl, we hear about those things a lot, but we don't necessarily hear about this type of approach very commonly. At least I don't.
Thank you. Any other questions or comments for Dr. Lavin?
So Lindsay,
So it looks like there's,
yeah, go ahead.
yeah, one question. What is abuse? I mean, you can, you know, the DSM lists different types of abuse, if you will. I try to just generalize it. You know, does bad stuff happen when you obtain, use, or recover from opioids, right? And we can make that into kind of whatever we want within reason. But again, usually what I tend to see is that you have somebody who has a true, probably medical need for pain treatment. You could argue whether or not it should be with opioids, but the need is there. Nobody is going to prescribe the patient appropriate treatment because of bias or the patient's history or so on and so forth. And so if you can elicit some history of overuse, potentially misuse, that sort of thing, that meets diagnostic criteria, that checks that box for buprenorphine use. And again, oftentimes, not only does it help them with their pain and decrease the risk and all that kind of stuff, but buprenorphine itself is actually quite helpful for depression and anxiety and stability and all that kind of stuff. So it really can be pretty helpful. So I think, again, back to your question, what is abuse? I think it's going to vary for the person. But if you can objectively say, hey, there are bad things happening because of an opioid related problem, and that has the potential to happen again, or they have the potential to benefit from treatment for the opioid related problem, I'd say that checks the box, and I would offer them Suboxone and everything else.
So I asked because I guess that was my problem, is that I had my first, or in this latest history, right? I went to the ER back in February, and then I actually got prescribed opioids because I had kidney stones that were passing, and those are really painful. So this time when I went back to my doctor, I had another kidney stone, and he wouldn't prescribe me anything because he's like, oh, well, you have a history of opioids. I was like, well, yes, but this is painful, and it's something I need medication for. Like, this is not a fun experience, right? So who decides like what this history is and like how that plays into what you're prescribing?
Again, it's going to depend on the provider. I think usually folks with some sort of addiction training or more familiarity with it, I think, are going to be potentially more helpful in that regard. But yeah, we see it a lot. You know, I'll see folks on the palliative service that have metastatic cancer and they're not being offered appropriate pain treatment because they used heroin 30 years ago. It's like, that doesn't make a lot of sense. You know, like neither does treatment with buprenorphine necessarily in that case, but just because they have a history does not mean they don't have a true need. And I think there's a way to prescribe appropriately to where you're helping them, you know, feel better and not have a miserable experience, and also not making things worse.
And so, and I suggested it before, but it would be really nice to have some type of list of doctors that were more knowledgeable about substance use and more knowledgeable about these things to send our, to send people that I work with to, and to go to myself, obviously. Because I do work a lot and I do see this all the time with people who are on the streets or who are, going through these problems that are real problems that really need to be addressed and they can't find good care.
It's a big issue. It's a big issue. I agree. Anna, did you have a question?
I was just going to ask if you could speak to the opportunity to like ask the patient or the client specifically, like, do you feel like you struggle with these things? Like, can you talk to the role of the provider and like asking those questions and helping patients and clients like self-identify with their own risk factors? Because as much as we might try and glean like all the things that we can, like, I think that I certainly came into the field and grew up with a lot of teaching that people are just going to do that, whatever they have to do in order to get opioids. And I think a lot of people actually want a good life for themselves and are willing to say, like, this is something I've struggled with, and so I'm nervous about it, versus I think I'm okay and I need help with pain. Can you just talk about that a little bit?
Yes. Here's how I'd sort of think about this. And I think, and correct me, please interrupt if I'm way off topic here, but I think a way to illustrate what you're asking is actually with people who use alcohol. And usually when we're talking with folks, there's oftentimes a perception that I'm not quote unquote an alcoholic, then I really don't need assistance with my alcohol. So in other words, like I wouldn't benefit from an anti-craving medication for my alcoholism unless I'm actually an alcoholic. But also I wouldn't benefit from treatment for an opioid use disorder unless I actually have a significant problem. Is that kind of what you're asking?
Yeah, I think so. Yeah.
Okay. I think it varies. So, it's important to remember that oftentimes our medical system is going to basically penalize people for being honest. And what I take a lot of time and certainly a lot of effort with the patient to hopefully create a situation that's kind of a safe space. So I'll say things like, I will try to identify with where I suspect they've been. So I may say something like, God, looking at your medical history, I can tell you've been in for pain-related things before. Oftentimes in the system, we don't treat people like we're coming in with pain very nicely. Like, I bet you there's been times or two when you've been kind of mistreated or people have called you drug seeking or something like that. And usually they'll say yes, and you're sort of aligning with them. And then what I like to do is talk about basically that, hey, oftentimes if you share these things with folks, they're going to use it against you. They're going to take away the pain medicine. They're going to give you a Tramadol or whatever, Then I segue into, basically there are some things I can offer, but I really do need all the information. And really what I try to use is that information to help people. And sometimes they'll give you history, and I'm looking for a little bit, some admission of overuse, some admission of obtaining a prescription opioid from a friend or a family member, something like that. And my thinking is, if they're going to give me some of that, the odds are there's actually more of it that probably will come out with time. But I think that's enough to get started. Now, usually sometimes what the patient will say is they may interrupt me and say, hey, I'm not an addict. I don't use heroin, something like that. And so then I put a lot of effort into saying, hey, listen, like these things exist on a spectrum. We're not really talking about that. We're just talking about, do you feel like there are times when what you have to go through to get treatment for your legitimate condition causes problems? Like, for example, it looks like you're spending, 3 weeks a month in the hospital. Like, it must be really hard to do that. And also, complete your other responsibilities outside of the hospital and that sort of thing. So I think if you can sort of navigate the conversation away from the dysfunction that usually has stigma, the legal stuff, the overdose stuff, that kind of stuff, and much more pedestrian, commonplace dysfunction or difficulties stemming from untreated opioid use disorder, a lot of times they'll give you enough to open the door, and then in time, more will come out. Does that answer your question?
Yeah.
Thank you so much, Dr. Lavin, and thank you all for joining this discussion today. In the interest of time, we will request Dr. Walker to quickly summarize the case for today.
Yes, so we talked about Dr. Lavin's patient who had significant substance abuse psychosis, and it came out that they had chronic pain and we're using psychotic inducing substances to sort of alleviate pain. And with treatment of buprenorphine, had the ability to kind of stop using those substances and get better, and also have pain control, and kind of talking about stigma and where kind of opioid use disorder plays a role in when you diagnose it and things like that. I think that's about it.
Thank you so much, Dr. Walker, and thank you all again for joining today's echo session. As a reminder, to earn CE credits, please text the activity code 10095644 to 844-502-1338 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email bvaltx@utisco.edu. We look forward to seeing you at our next session on Thursday, March 21st. I'm sorry, Thursday, April 18th. I apologize. Have a great rest of your day. Thank you.